All right, folks. So this is not a talk on how to manage pain in OUD patients on buprenorphine. This is the other direction, using buprenorphine for pain management, even if it's the film. And so all of these disclosures say, are you going to talk about off-label use? Yes, off-label use is one of the clear topics today, using the film for pain. I am a clinical adjunct professor at Madison and still teaching the fellowship just like I did for 33 years before I was on the core team. Have a number of things I'm doing in my life with my consulting practice, and I have a lot of consultation things going, plus a lot of expert witness work. So buprenorphine was approved as a SCED 3 sublingual product for opioid dependence, and this is what we all know, the Suboxone, Subutex. These are the various forms approved for the treatment of addiction. Included in this slide is the Probufene implant, the Sublocade injectable, and Brixadi, which is on the cusp of being approved. And Bunavail is here, even though it's no longer made. And the pharmacology is really not the focus of this, but just to review very quickly, it binds at the mu-opioid receptor, but also is an antagonist at kappa and antagonist at delta. And it also works somewhat on another receptor where the ligand is something called orphanin or nociceptin. It's had two different names. And so it's not an opioid, so it was called an opioid receptor-like receptor. So it's like an opioid receptor, and it does the same things downstream, but it's not an opioid that agonizes it. And there's been some thought that the activity of this receptor is a part of the mixed agonist-antagonist feature because it turns on and off the nociception and even euphoria at the same time. Here's the key. There is a ceiling effect for respiratory suppression, but not for analgesia. There's lots of misconceptions concerning potency. I do have for you a whole long reference list, and the names are to the authors of these things. So respiratory depression is quite a concern when you're mixing it with all sorts of sedative things, including in this statement, gabapentin, soma compound, and definitely include the Z drugs in the list. As far as metabolism, the cytochrome, it's 3A4, not 314, sorry. If you do mix this with other things that are metabolized by the same system, you can raise serum levels and worsen sedation. But it is interesting that using the same in vitro assays that the pharmacologists use to say that there's a ceiling effect of respiratory suppression, morphine produces the same thing. Bob Raffa is an interesting pharmacologist who I've gotten to work with in the last few years. Wrote a very nice article. So the kappa receptor activity is important. It may be involved in the fact that it looks like buprenorphine, rather than causing hyperalgesia like full mu agonists, is anti-hyperalgesia, which is a very interesting phenomenon that I learned about while researching this talk. Again, the Davis article talks about that. Also, the kappa receptor antagonism may be involved with antidepressant activity. Now, the whole topic of opioids in general and treating depression is interesting. I have found in my buprenorphine practice, if I have somebody that seems to have major depression, but is not on antidepressants, and I'm starting them on bupe, I do not start on antidepressant until I see how much of the depression responds to the bupe. So here is an article about using this for treatment of depression. So again, I want to get through the pharmacology slides quickly, and may actually not say any more of those because I want to get to the main issue. So again, the Kress article has very good things on various effects, the anti-hyperalgesic effect, the fact that other opioids suppress the immune system and buprenorphine does not. It's also interesting that buprenorphine's activity is not just at the level of the brain, it's at the level of the dorsal horn, and there's spinal analgesia from this product. Um, it is largely metabolized through conjugation more than oxidation, even when we talk about the cytochrome system, and a lot goes out in the stool. And it is safe to use in people with renal failure because you don't get as much accumulation as with other opioids. It's also good in people with liver disease. So it's interesting that if you just look at the pharmacology of buprenorphine and compare it to other opioids, it's got a lot of advantages where you may not want to use one or another full agonist. Buprenorphine is safe in a lot of ways. Serotonin syndrome. Fentanyl and oxycodone are well known to lead to serotonin syndrome. Buprenorphine does not. There are certain, we know all sorts of products for addiction, but there's actually products for pain, and that's what we're going to talk about now. What are the different products? Buprenorphine has been around. It's actually Schedule 3 as an injectable product for acute pain management. So it's been around now for 40 years and still is around. And probably should be used more in inpatient settings in the place of other opioids for some of the pharmacological benefits we've mentioned. Butrans came out in 2010, a transdermal system, BTDS, buprenorphine transdermal system. It's not approved for opioid use disorder. There's different strengths, and it's interesting, in the US, much smaller strengths than in the UK and in Europe. So, and the bioavailability of the different products is probably comparable. It's interesting that the manufacturer here asked the FDA to approve these strengths. You should wait a minimum of 3 days between your dosage increases because it takes 3 days to get to a steady state. There certainly are a variety of side effects that you get with other opioids, but it looks like it's better than the fentanyl patch in a number of ways. But 25% of people can get problems with regard to a dermatitis. So let's kind of get through this. Again, the maximum dose in the United States is 20. And the issue of equivalence with other opioids is controversial. There's a lot of different bioequivalence tables, but if somebody's requiring more than 80 milligrams, this says you're not going to get that much effect from the Butrans patch. I did find interesting that just like we say you should reduce methadone to 30 before switching to bup sublingual in addiction treatment, it's also recommended that before you switch from another opioid to Butrans, you get down to 30 on the full opioid agonist. QT prolongation was probably the thing that made the manufacturer not want to ask the FDA to approve at higher doses, but the European product Transtech is used in much higher doses, really without much real world cardiovascular problems at all. But obviously there are some issues with other medications that can prolong QT. So there are some QT issues even with this very low dose buprenorphine patch. Now the film was developed for the addiction product called Bunavail, which had so little market share that the company just stopped making it. But they quickly took the exact same engineering and put it in the Belbuca product. And so if you're not familiar with this product, I mean, I was on a physician advisory board for Bunavail, but now that's defunct. But these were the slides that were used and the FDA approved about the BEMA technology. It's a bioerodible mucoadhesive. You put it up against the inside of your cheek, and there's a backing layer so that there's only unidirectional flow of medication. The medication only goes into your capillaries and doesn't go back into the oral cavity. So bioavailability is much greater, and the taste is pretty good. And you can put it in there and then begin talking and drinking water immediately, as opposed to a sublingual product. So this is the buccal film. These are formulations that people need to think of. These are certainly FDA approved for pain, but the FDA indication says it's for people that need around-the-clock coverage. It's not just for acute pain, it's for very chronic pain. But of course, off-label, you can use anything. It is interesting that the bioavailability of the film and the tablets are different. We know that because we say that 5.7 of Zubsolv equals 8 of buprenorphine, which really makes you wonder when they switched the Suboxone product from film to tablet and didn't change the dose recommendations. Does it work for pain? Well, this paper by Raffa et al. Says there's a lot of different mechanisms by which pain is relieved, and it's not just a direct anti-nociceptive effect at the mu receptor, but it's got very good analgesic activity. It's a very nice analgesic. And the Raffa paper looked at all sorts of things, comparing IM bup to IM morphine in different surgical situations after coronary artery bypass, a whole range of circumstances where it's been shown to have excellent analgesic effects. It's been used for years in people with chronic cancer pain and found to be effective for a huge number of people. And a big German study with 10,000 patients, 80% reported it was good or very good pain control at the end of this study, compared to only 6% at the beginning of the study. It really is an effective analgesic. And this author says equivalent to other opioids with a lot of better comparisons on side effects. There's ceiling effect on the euphoriant effect and on respiratory depression, but not on analgesia. So again, all of us in addiction treatment look at the ceiling effect, but there is no ceiling effect on analgesia. The more you give, the more pain relief you get. Again, less adverse effects compared to morphine and fentanyl. So we talk about it being a partial agonist at the mu receptor, but it's fully effective as an analgesic. And to call it, we should not think of it as being only partially effective. And I said this earlier, get down to 30 before you switch from other things. So will full opioids work in the presence of bup? In most patients who have gone through surgical procedures, this is what was taught at one point, to stop it. Now we're saying it should be continued. In these scenarios, you continue with something with high binding affinity. And it really is interesting that fentanyl seems to work on a slightly different part of the mu receptor. And is that coming, Tom Costa? And I gave him a phone call a week ago, and we had to talk about this because he was doing bup research in the 80s. And so he says that fentanyl actually works at the beta-arrestin part of the mu opioid receptor, not the primary site. So, I've always heard clinically that fentanyl can bypass blockade of or receptor occupancy of buprenorphine, and this is sort of why. So, again, in acute situations, fentanyl and hydromorphone is suggested. All this does for me, however, beg the question of people using fentanyl to get high when they're on bup. If you can override it for pain, why can't you override it for euphoria? It's kind of interesting. But at any rate, so at full doses, it seems to act like a full mu opioid receptor, even though it looks like a partial agonist when used for addiction. Again, there's a lot of misconceptions that it should be stopped during the perioperative period. What I've seen, and by looking through all these papers, reducing your bup to 8 and then adding the other drugs is probably the smartest thing. You want to free up the number of receptors where other things could work. But you can, if you're on bup, people won't need as much PCA. You can give them together. They'll both work, but bup reduces the need for other opioids. And again, it's a much safer drug. Patients prescribed immediate release opioids reported lower pain scores when these other things were added to bup patches. So if somebody's on a bup patch and not getting adequate pain control, possibly because of the U.S. ceilings on dose of 20, and you need to supplement, you can get results. And this was in this very interesting study. So this is a surgical thing saying if you're on full mu opioid receptors, if you're on, let's see, patients may continue to require the full, after they leave the hospital. So if you add as a supplement, you may want to keep them on it. And then when you taper off the full agonist, they're not going to have any discomfort because bup is in place. So keeping that background of bup is interesting, and that's certainly what we're doing on the consult service at UW these days. Again, but if you get down to 8, you'll have more receptors open for other things to work. It is interesting that you can get good clinical relief of pain even if you only occupy 5 or 10% of receptors, says this whole paper by Howard Height. So off-label use of sublingual for pain. I refer you to the Coate paper and the Crest paper. It's not off-label in Europe because they don't use the FDA. They just use it, and it works just great. It's effective for pain. This is the sublingual stuff. It's not used much in clinical practice, but it really does work nicely. The DEA does say it's available. The Howard Height and Gourlay article called Open Letter to DEA was an exchange back about 2005 or 6 with different DEA people who gave them answers in writing that said, we're not going to stop you from using it off-label. I remember a big letter that was sent out to all waivered physicians at about a dozen years ago. So just stop. Just don't think of using these things crossways. And the DEA doesn't have the right to say things like that. And I contacted the DEA, and I couldn't get a copy of the letter from them. I have it in a box somewhere, and I couldn't find it. But they sent a big warning letter. Don't do this. But the DEA doesn't have that authority. It's the FDA that controls medical practice, not the DEA. But at any rate, again, there's all these different effects from full opioid agonists that just don't show up with buprenorphine. 10 trials, 1,200 patients. Does sublingual work? Yes, with less nausea, less dizziness and vomiting. So in Europe, they've been using bup tablets since 1982 in surgical pain situations. So if you are going to use it for pain, onset 30 to 60 minutes after the dose, peak dose 1 to 4 hours. But again, a once-a-day dose will not give you anywhere near the pain control of a 4-time-a-day dosing. Again, the equal analgesic tables are highly debated. One says it's up to 100 times more potent than morphine. That seems like it's excessive. But this big study by Deitch looked at sublingual bup versus full mu agonists, and they found a really nice drop in pain scores. These patients did not have an increase of their quality of life scores, interestingly. And so a nice article, if you want to go find it, that it really does show the drop in pain scores. And this is what happened when people were inheriting patients on these high doses before we realized what bad medical practice this is. And they found that there are good reductions when you use sublingual bup in people who had previously been maintained on very high dose opioids. If you are writing it for pain, you have to put on your prescription or call the pharmacy, whatever, and say, this is for pain, not for addiction. Now, this whole thing of X numbers looks like it may be short for the world based on the big announcement yesterday from the feds that they're going to stop requiring X numbers for up to 30 patients. And if you didn't see that, Google it. It just came out yesterday. The AMA has a press release that just came out. But at any rate, put for pain on your prescriptions, and it won't count against your census. And they should fill it even if you don't have an X number. Well, I did get through all those. That was the whole bunch. A big, long bibliography for you. And if there's any questions, it looks like we have 8 minutes. For those that weren't counting, that was 62 slides in 14 minutes.
That's
So
a record.
we can get through these.
Well done.
Thanks.
This is Paul. That was a fantastic presentation, and I'm looking forward to getting those references. I hope that you can, Kelly, you can get those posted. I made a phone call to the company about this expectation in the prescribing information that you're supposed to down titrate the other opioids before you switch them over to a buprenorphine for the treatment of pain. And I wondered, what is the data that suggests that you have to do that? And the answer that I got back was that that's the way they did it in their clinical trials. They assumed that by giving the buprenorphine that they would displace the opioids and cause a withdrawal syndrome. So they basically included that in their protocol design. They do not have data to show me that there is a substantial withdrawal effect if you add higher doses, you start patients on buprenorphine at higher doses of morphine than you mentioned, or that they mentioned in the prescribing information. So I'd be curious if anybody's ever tried starting the buprenorphine on patients with higher doses of other opioids.
Well, of course we have. This is people that aren't taking it for pain, but they're taking opioids to get high. And they do get precipitated withdrawal. So, there's a lot of mystery in this to me, a lot of mystery. What happens in the real world versus what happens in vitro things that they use to back up some of their claims. What we did not get into here was the Bernese method, which is using very small doses of bupe to introduce, and start at 0.5 milligram, then 1, then 2, then 4, and you don't get precipitated withdrawal. So one idea is get your full opioid down to 30 and then use a pretty decent dose of bupe. The other is when you're adding bupe, add it extremely gently. And again, some doctors in Bern, Switzerland, call this the Bernese method, and that was beyond the scope of this talk. But Paul, I'm not interested in giving 4 milligrams of bupe to somebody who's on 120 milligrams of morphine, because unless I have a emesis base in there, I just think you're going to really precipitate withdrawal.
Good to know.
Paul, I've been struggling with that question. I've been using a lot of bupe for pain at the pain clinic, and have a woman for whom titrating down to the 30 MME is just the end-all be-all barrier for her. And I'm kind of like, I just don't get how, her being at 40 MMEs versus 30 could really matter that much. But she's also a very cautious woman, and I don't want to cause a bad effect. So we haven't gotten there, but I'll keep you posted if I do it, because I just think theoretically, if they're close to it, for sure, it just doesn't make sense to me.
Well, that's one of the two barriers that I see for using buprenorphine more and transitioning to buprenorphine more, is that down titration of the opioids and the insurance coverage, which is still a problem.
I think Sophie Kramer's question in the chat is quite important, and I'm not sure if I'm going to say exactly what she was thinking, but I've run into the problem too. I've been doing a lot of research of bioequivalencies, because the formulations that are approved for pain are significantly lower doses than the sublingual films that are approved for opioid use disorder. And so for patients on very high doses of full opioid agonist for pain, can you use the sublingual? Surely you can without an X waiver, you can write for pain. And, from an efficacy perspective, it should work, but can you get it covered by insurance? Because allow you to fill it, but you might have to pay cash for it, which can be prohibitive. But I watched one of the ASAM pre-conferences recently, and they were saying that pretty universally, because you also don't want to falsely document that a patient has opioid use disorder if they really have no such history, because that could have ramifications both on the patient and the medical record, things like that. But many patients who have used other opioids for pain have dependence without a use disorder. And so you can usually get it approved by payers for dependence, and not have to feel like you have to write an opioid use disorder in the medical record, which I have found empowering to patients who really don't have use disorders and don't want me documenting such, and I don't want to falsely document anyway. So, but there are some limitations. I mean, I've come into some situations where getting the formulations approved for opioid use disorder for pain are difficult. I have on Medicaid recently gotten both Belbuca and Butrans for patients for pain. So I think they're covered, but welcome anyone else's experience.
But transdermals definitely should be covered because that's what the whole point of them was. So any insurance company that didn't do that, I'd write them up to the insurance commissioner. You've got to approve those. It's discrimination if you don't. So those the FDA approved for pain medications, the Belbuca and the Butrans.
Right.
The question is using the sublingual films.
Right.
And the prior auth systems will often kick you out, but I have been willing to call medical directors of pharmacy benefit companies and to plead my case. And so when I get a rejection, I'm willing to appeal it. It certainly takes time, but it'll be very interesting to see how these PA systems change with this elimination of the X number, because that used to be an easy way to make a distinction. That you even Medicaid, you put on the form, do you have an X number? And if you don't, then they go nuts and say you can't use this for addiction.
It's a compelling argument too to say. So you're telling me I can't use sublingual films off label, so you'd prefer me to use the theoretically more dangerous full opioid agonist for this?
Exactly.
I think you can get the PA approved.
Yeah, it's you have to talk to somebody. It won't happen automatically because the general staff who goes through this stuff are trained to kick things out. So it's got to be an appeal. But you're right, and that was the point of these articles. And if you read these articles in the biblio that you all have access to, really, it's just a better drug. Why would you want to be using all these other full mu agonists when you have this very effective pain med? But again, split doses is the way to go. And what I've even found is if you say Q4 hours while awake, that's going to give you 5 doses a day, either 7-11, 3-7-11 if people get up then, or 6-10, 2, 6, and 10 if they get up at 6 and go to bed at 10 p.m. So Q4 is 5 doses a day. QID comes out to about every 5 hours. And so I have a lot of people on every 4-hour dosing, 5 doses a day. And that's the way to maximize the efficacy of this as a pain medicine.
There's a question from Ritu in the chat. Are people using multiple, the BTDS, the Butrans patches to get strengths closer to Europe? I don't know. I would imagine some are, but probably insurance doesn't pay for it if more than 20, but I don't know, Mike, or anyone else. Has anybody seen that?
I think, Kelly, you're going to end up being the leader on this because you're working in a pain clinic. You'll be able to tell us a lot about this as far as your experience. But I would think that a lot of payers would say, heck, we're not going to give you 60 patches a month or 90 patches a month. And if push came to shove, get an EKG and prove that the QT is okay. Mm-hmm. So no, I don't know if people in the United States doing that, Ritu, but it just shows how smart you are, Ritu, to ask that question.
This is Sheila. I just had one comment. This is for Dr. Miller, just for his thought. From doing lots and lots of inductions, our folks this is in substance use disorder. Our folks don't get all those nice tapers and things. We basically say, stop using your opioid 24 hours before we do the induction. They come in, we're expecting to see at least some mild withdrawal symptoms. And if that's happening, we go ahead and start the buprenorphine. We have not been having problems with precipitated withdrawal. So I mentioned that from the observation that if there's translation into the pain group, if there's the opportunity to not have to necessarily take them down to 30, but more importantly, that they not take a dose within a time frame prior to that induction. Because of course, the immediate removal of or treatment of the withdrawal symptoms makes the people receiving it very happy. And so they're feeling good very, very shortly. So just an observation, Dr. Miller.
You're absolutely right, and I didn't say that in the talk. It was in some of the papers about the washout phase, and the washout phase is based on the full agonist that they're using, and so up to 24 hours for the short actings, 72 hours for methadone, that sort of thing. I think one of the problems, and of course, addiction patients are at risk if you have them wait for a day or two, and some people can't. And so we've seen people that they'll use heroin before you get to that first bupe dose because they just can't wait. But most of them are motivated and they can wait. Some of these pain patients just say, "You're going to ask me to do a 2-day washout? Ain't no way." And so I think the pain population actually might be less agreeable, but again, not having worked in a pain clinic, I can't say that for sure. But what you said is exactly right, Sheila.
I just was looking at is taking the Band-Aid off quickly rather than facing long periods of the decreasing dose with the fear that goes with that. So just a thought.
You bet. So I guess if you didn't get the email with the bibliography, just let us know. We can get it for you.
Melissa, do you have information on the insurance?
Yeah, I was just going to talk quickly. I know we're at time, but just regarding the insurance and the possible changes with the DEA waiver, just to let everybody know, it's really insurance dependent, but a lot of these, especially for the Suboxone films, insurance actually require us to put in a diagnosis and attach a ICD-10 diagnosis code. And so that's what allows us to get it through or not. We can actively pursue prior authorizations for some of these medications, really insurance dependent, and you can push it up the chain. But I will tell you, Medicaid is the toughest one of all. I have appealed and appealed and appealed. I have never had Medicaid approve a Suboxone for pain. That's not to say it will never ever happen, but that's for Wisconsin Medicaid specifically. And of course, every insurance has formularies as well. So of course, they go into agreements with these drug manufacturers. They get rebates from drug manufacturers, which is how they choose their preferred products. So for example, Medicaid will cover Butrans, but for the Belbuca, it needs a prior authorization. They need to have failed a certain list of medications in order to get a prior authorization. It requires a paper PA that can take 21 days to get approved. So that's just an example of the steps you have to go through to get these patients these different medications to help support them.
Yeah, and the reason I put my slide in there about, disclosing that I was on a physician advisory board for the manufacturer of Belbuca, but it wasn't for Belbuca, it was for their other product, but the engineering is the same. And I'm a real believer. And so the way that stuff is engineered, I think going to bat for people to try to get authorization for Belbuca is it seems reasonable to me because of, again, the way the medication is delivered through this buccal route. So,
Well,
thanks everybody. Nice seeing everybody again.
Yeah, thank you, everybody. Great talk and learning, an interesting area. Again, if anybody has a case for next month, please reach out to our team. We'd love to bring it to this venue, and we'll see you all again in a month. Thanks, everybody.
Okay, bye.